evening, everyone. Just take your seats when you get the chance. My name is Bryan Walsh. I'm a writer with Time magazine, and I'm going to be your moderator for this exchange on how to keep global health in the American dialogue. You're all doing a very good job by coming to the panel, first off, and helping us with that. As a member of the media, usually I think of global health stories as fulfilling three conditions. One, they take place very far away, which is usually very far away from where your editors or your audience is. They often have a very high death toll, and too often they get very little space in the media. Now, that's not always the case for Time magazine. If I'm allowed to plug ourselves a little bit, we, I think, have reported pretty thoroughly on global health issues in the past, and as you'll see here, the NewsHour really is second to no one on this subject. But keeping these seemingly insolvable problems in the public eye, whether it's malaria in sub-Saharan Africa or TB in Southeast Asia, isn't easy. Attention wanes from audience and editors alike when they perceive that a story just doesn't have anything to do with them. But as we should all know by now, there's really only one globe in global health. And I learned that personally during the time I spent reporting on avian influenza over the last several years, wading through backyard chicken farms in Southeast Asia, looking for new cases. Suddenly what happened in a tiny Indonesian village that I visited called Kubus Sembelang, where the H5N1 virus passed from person to person to person back in May of 2006, sparking fears of a pandemic at the time, had enormous implications for the rest of the world. Now, of course, it turned out that H5N1 wasn't the virus that triggered a pandemic, at least, so far. But we have seen as the new H1N1 virus, it's tough to keep those straight, has raced around the world, we learned just how connected we all are. Global health is our health. So we need reporting, along with the work of great NGOs like the Gates Foundation, to help keep us on top of that. Now, fortunately, we have a great panel here to talk about that tonight. First, we have Les Crystal, the president of MacNeil-Lehrer Productions. For 22 years before that, the group's executive producer. If I were to give you his entire resume, we'd probably be here until Monday, but among his other positions, he's been president of NBC News and executive producer for NBC Nightly News. Here we have, to the far left, we have Ray Suarez, who currently works with NewsHour with Jim Lehrer, but he has a wealth of experience in journalism before that, hosting Talk of the Nation for NPR, working nationally and internationally for NBC's Chicago station. He's the author of two books, The Holy Vote, The Politics of Faith in America, and The Old Neighborhood, What We Lost in the Great Suburban Migration. To my right here, we have Fred Lazaro, a correspondent with NewsHour, the director of the Project for Undertold Stories at St. John's University, which combines teaching with putting a spotlight on badly neglected international news. He's also directed films from India and the Democratic Republic of Congo for the documentary series Wide Angle. He led the first American crew to report on the crisis in Sudan. We have Michael Madnick at the end here, the Deputy Director for External Relations and Global Health Policy and Advocacy at the Bill and Melinda Gates Foundation. He works with governments, international organizations, and other partners to help further the Foundation's goals. Before that, he also served as Senior Vice President at the United Nations Foundation. And lastly, to my left here, Matthew Dowd is the founder of the political strategy group ViaNovo, and he spent the last 25 years shaping campaigns for CEOs, corporations, foundations, and candidates. He also wrote the best-selling book, Applebee's America, and he was chief campaign strategist for President George W. Bush and for California Governor Arnold Schwarzenegger, and he currently works as an analyst for ABC News. So we're going to start with Les.
Good evening, everyone. Thank you very much for coming. This small group reminds me of the very loyal and dedicated audience that the NewsHour has and that we pride ourselves in having. So we're most appreciative. And also most appreciative to have this opportunity to participate at the Health Forum and to talk to you about our coverage. Health issues have always been a basic objective in terms of coverage for the NewsHour. And we've had foundation support for that for many years. And we were on the case early when it came to certainly the what we now can call the AIDS pandemic. But one of the obstacles that we face is when there's a story that's overseas, it takes a lot of resources, and resources are hard to come by. And so that's why we have a debt of gratitude to the Gates Foundation that has made it possible to launch some very special coverage of global health issues. And actually, I was reminded at dinner tonight that the idea of an association between the NewsHour and the Gates Foundation really was born here about 4 or 5 years ago at the Ideas Institute, where I think Jim Lehrer was in the audience, and the subject of global health came up, and there was a question of why aren't we doing more than we are doing? And certainly resources was a key to why we weren't doing as much as we'd like to do. So it took some time, but it's led to a major 3-year grant from the Gates Foundation for us to go out and cover all over the world what's going on in this very important area. We have a commitment to do about 15 to 20 major stories a year in addition from the field, in addition to the studio discussions that are, as you know, a very natural part of what the NewsHour does. And Ray Suarez on my left and Sam Lazaro on my right have been the key point senior correspondents who've been out covering these stories. Fred has been doing it for a long time, and Ray's extensive experience, but has become even much more intensive now that we've got the Gates Foundation grant. And since it began, we've been since January Ray's been to South Africa and to Mexico and Tanzania. Those stories haven't been on the air, the Tanzania stories, yet. They're in the process of production, editing, and scripting. And Fred's been to Cambodia and has been to India. And one of our other reporters, Benny Ann Bowser, has been in Atlanta at the CDC as part of our coverage of the flu epidemic. So it's been, I think, has enhanced not only our coverage of this important issue, I think it's enhanced the program. We also have, as a companion to the coverage, a very extensive online Global Health Watch page, which covers the major stories that are going on. It has insider forums and interviews, archives of all the things that we do, and also resources to other public broadcasting programs that are covering this story. And so it's something that you can go to get an idea not only of what we've been doing, but what supplementary information that we have, including a lot of educational resources. And each of you, I believe, has a form at where you're sitting, and I hope you'll fill it out, because if you're interested, by filling it out, we'll be able to give you an alert when we're going to have a story not only on global health, but general health issues. And at the same time, you'll see when you go to our website that you can subscribe to podcasts and also to RSS feeds. So it's quite extensive, and this has been just a major operation for us in terms of its importance and what we're covering, and very gratifying. We've had a lot of excellent viewer reaction. I want to read a couple of the comments that we've had. To give you an example, naturally I'm reading you only the positive ones, not the negative ones. But I think, frankly, they've mostly been positive, and I think it's an example of what I'm about to read of why what we're doing is so important and why it's so valuable. This is one after Ray had been in Mexico for a series of stories. Ray Suarez did a fabulous job with this report tonight about Mexico's response to the flu. I got a much clearer picture about some of the positive things that are being done in Mexico that may be helping to curb the crisis. Ray's report is an example of why I watched PBS Jim Lehrer NewsHour. And this other one from a viewer who says, I grew up in Durban, KwaZulu-Natal. I was touched by your series and like you do something for the school that Ray had covered. So we know that we're touching people both emotionally but also intellectually. And it's wonderful to see the value that we get from our viewers in terms of the kind of coverage we provide, which, as you know, is both in-depth and we try to make it very objective and to carry the complexity that these stories have. And now at this point, we're going to turn it over to the people who have been doing all the work, and Ray and Fred are going to talk about their recent trips.
All right. Ray, you want to start off?
Sure. Thanks. I'm not an advocate. I'm not a health expert. I'm not someone who's trying to drive the audience toward some conclusion about what ought to be done in the places that I cover, but always put front and center the story and go at this work convinced that even though you may not be living in a township outside Johannesburg, even though you may not be exposed to black fly bites to get river blindness, that a good story will engage you and bring you into the world that these people live in. And we, during the time that we were in South Africa, we paid special attention to tuberculosis because it's become the single most noted cause of death on death certificates in the country. And you may have been hearing all about HIV and the terrible toll that AIDS has taken in South Africa over the last several years. But now that they've had a change in policy and a large number of people are on antiretroviral drugs, more people are living with AIDS than dying of it. But there's such a large immunosuppressed population in Southern Africa that tuberculosis, a preventable, treatable disease, is spreading like wildfire, and co-infection is now a massive public health threat. It's not just people in garrets in Paris on Christmas Eve 120 years ago who were getting tuberculosis and dying at the end of a lovely aria. It's millions of people around the world are contracting this terrible disease, and for want of treatment, for want of comprehensive national health services that can find out where they are and get them the medicine they need, they are dying of this. And developing countries need every set of hands and every strong set of shoulders and backs they can have to build themselves out of the terrible poverty they live in. So let's take a look at a story I did on co-infection and tuberculosis, and we can talk about it later if you like, but let's take a look. Without question, the biggest challenge of the tuberculosis epidemic is treatment. The standard treatment for TB is an arduous 6 months of daily medication. If medication is not finished, deadly drug-resistant strains of the tuberculosis bacteria can develop. That's why at the Prince Cyril Zulu Center, hundreds of patients show up every day before work, show their card, and swallow their medication in front of a health worker. It's called DOT, or Directly Observed Therapy. It's promoted by the World Health Organization as the gold standard for care.
The biggest problem is after the first 2 months, they have been on TB treatment. After 2 weeks, they start to feel really, really good, and then after 2 months, they're actually feeling so much better. And I think after the 2 months review is quite often when we have the most people dropping out, and it's really worrying. At the moment, I think we're losing about 23% of our patients.
Following a TB patient through 6 months of treatment in rural areas is even trickier. We're about 7 miles from the clinic, not that far, really. But remember, when you're talking about patients who are among the poorest of the poor, $1.50 for a round trip in a taxi service is far beyond reach. And remember also that we're talking about patients who are still often quite ill. So walking any distance is out of the question as well. The answer? Bring the clinic on the road, where the patients are. On a February day, late in South Africa's summer, the temperature tops 100 degrees. Jabu Makatini, a social worker, heads out on foot to observe tuberculosis patients taking their medication. The program is partially funded by the U.S. Agency for International Development. Most residents in this rural area are poor, many are hungry, and taken without food, TB drugs can make you sick to your stomach.
The major problem in TB is compliance. Are we saying people who have TB are different than us? They are not. But the circumstance they live in, unfortunately, make them at times not to take treatment.
Very few districts have money for programs like this one in Ilembe. Dr. Machi says tuberculosis funding has been overlooked by the international health community, leaving the treatment unchanged for decades.
It takes 6 months to cure a patient, which is a long time. Imagine if tomorrow would be told there's a drug that can cure tuberculosis in 5 days. Is that impossible? It's not. Therefore, we need also to tell the international world that it's time to invest in developing new drugs.
As it stands, only about 70% of all patients in the KwaZulu-Natal province will finish their treatment.
That is what creates the problem. Because then what we've got is we've got incompletely treated TB. And that lays the foundation for getting a resistant TB. The organism has an opportunity to interact with the drug and then develop resistance to the drug, which means that our two major drugs that we use in the treatment of TB, the mainstay, the backbone of our treatment, are not available. That's a huge challenge.
Later on in that same story, you don't want to tell these kinds of stories in a lurid way to sort of grab the audience by the collar and rub their nose in it and say, look at this really stinks, look at how awful this is. Because in effect that distances people from the subject. But at the same time, the facts on the ground are so compelling that sometimes you need gee whiz moments in the story just to give people a sense of scale. So I visited one hospital that began with a single basement ward for patients with multiply drug-resistant and extreme drug-resistant tuberculosis. These new strains that are developing because of incomplete treatment, where the death rate for XDR-TB is 100%. The 2-year survival is like 1%. So it's basically a death sentence. If you have extreme drug-resistant TB, you die. From the single basement ward for MDR and XDR TB patients, they now are the entire hospital. 11 stories of nothing but MDR and XDR TB patients. Well, again, you don't live in KwaZulu-Natal, and you're not South African, and you're not most likely exposed to tuberculosis, but you are a human being. So there is ideally, if it's well done, some connection with what these people face.
Absolutely. Fred, you're up now. I see you're reporting as well.
Sure. I work typically with what we call undertold stories, which typically are in places where the tourists don't go, where in many cases the reporters don't go, places that don't have indoor plumbing. That's sort of the litmus test for a country and how much coverage it gets in many ways. So if you were in Africa, South Africa, and Nairobi, or rather Kenya, get covered quite a bit. But it's difficult to get into other places, but there clearly are stories there, and we try and find those and find means to get in and do them, typically partnering with NGOs who work in public health that have a great deal of credibility, and we sort of piggyback on that credibility, try not to make their lives too miserable or complicated, and get the story out that we think is in there and hiding. The story of polio is fascinating. There were 120 countries, if I'm not mistaken, that had polio 20 years ago. It's down to 4 now. And not surprisingly, these are countries that are very difficult to get to as a journalist. They're countries that have faced a lot of social turmoil. At least 3 of the 4 have. And we chose to go to Nigeria because it's probably the most dysfunctional place that isn't a real full-blown war zone. And yet it is so illustrative of the historical and the political ricochets in the farthest reaches of the globe of major events. And in this case, the Nigeria polio story, it was the story of the Iraq War ricocheting into northern Nigeria. So I don't fully recall the exact stretch that we have here, so instead of telegraphing what might be in there, I think it's probably best for us to roll it now, and we'll talk about it after we come back. So why don't we take a look at an excerpt of the Nigeria polio story.
For as long as he's walked, 48-year-old Aminu Ahmed Tuada has walked on his hands. His lower limbs are withered by polio. He lives in one of the last places on earth still threatened by the disease. But Tuada's is a story of success against daunting odds. He has a thriving business in tricycles used by the handicapped. But he has a much grimmer message that he tries to get across to parents as he coaxes them to immunize their kids.
I will tell him, do you want your son to be like me? Look at me, I'm a polio victim. I'm not joining army, I'm not joining police, I'm not joining even football.
Polio is spread mainly through poor hygiene and sanitation, problems in so much of the developing world. But it is easily prevented with a course of oral vaccines discovered decades ago, which wiped out polio in the United States. In 1989, a campaign was launched to eradicate it worldwide. The campaign against polio in Nigeria had been making progress, but about 5 years ago it began to run into opposition.
In 2003, not long after the U.S. invaded Iraq, a rumor took hold around Kano that the polio campaign was in fact a U.S.-led conspiracy against Muslims.
So people thought it was a plot by the American government to sterilize children.
So they think America doesn't like Muslims.
We listened carefully to their concerns, took members of that community to see how the tests were done, and in fact, I think the vaccines here were actually produced in Indonesia, a Muslim country. And so that was an important step in counteracting some of the fear and increasing the acceptance at the level of the religious leaders.
Now the vaccination campaign is again in full swing. Village by village, it begins with a town crier announcing the arrival of a vaccination team, urging parents to bring the young children in. Along with the oral polio vaccine, the children are also given a shot for measles, which still kills hundreds of children each year in Nigeria. Even with the blessings of religious leaders, experts say the campaign falls short in critical areas.
For primary care in particular, we have 774 local governments. The coordination was not optimal.
I mean, I also expected that, oh, thank God, during my term as president, we would finish this job. And that was the very moment in my own home state that the exercise was temporarily paralyzed.
And for countless children, the paralysis will be lifelong. Aminu Tuada and his wife Hadiza, who's also a childhood polio victim, say they waited anxiously for months during the suspended campaign before polio vaccines were once again made available.
But it was too late for your boy.
Yes, that's the reason it's too late, my boy.
Tragically, their 6-year-old son Umar was infected, a victim as much of political squabbling and official neglect as polio.
Now, the NewsHour viewers actually got to understand the Nigerian English a little bit better. We actually voiced over the English. I constantly run into this problem of English that isn't fully understandable to the American ear. That was 3 minutes or 2.5 minutes of a 9-minute story. It gives you a glimpse, and you didn't either see who these people were, but there's an American doctor from the CDC. The Nigerian gentleman was the global head of Rotary International, which has spent $1 billion to eradicate, or has raised $1 billion to eradicate polio. And ironically, the most obstinate place for this virus was his hometown. And this is a compelling story, and it's a struggle nonetheless for us to make it compelling, to make it relevant. I am eternally grateful to have the NewsHour as a vehicle to apply this stuff, and I also teach undergraduates, and this kind of material is just really invaluable in making it relevant. However, to do that, you need two things. You need a compelling story, and I thought we got it with this young man who had polio at the end. It's a very sad story. But the fact of the matter is a lot of these stories are downers, and it is difficult to hold an audience, I think, for stories that are downers. And so the thrust is always to try and be solutions-oriented, find out who's doing what. And we have a whole library of stories that not only talk about promising ideas to tackle a problem, but also, wherever possible, we try and have an American connection to it to make it that much more relevant to our audience. And one of the most compelling examples of that was a piece that we did last year in Malawi about a group of American doctors who sign up for something called the Pediatric AIDS Corps, run out of Baylor College of Medicine, where young, recently minted U.S. physicians, they've just finished their residencies, spend 1 year in any one of 11 sub-Saharan African countries treating pediatric AIDS cases. In some cases, like Malawi, they've literally prevented a demographic collapse in the society. And the connection to an American audience is just so ever-present, even in a moral vacuum. And obviously this isn't a moral vacuum that we're talking about here. So I do think that this is just really, really gratifying, because it also shows Americans in the world and engaged. And stunningly, this program, which pays the doctors a fraction of what they would earn in the United States, and they're ready to earn after residency. A lot of them have high debt loads that they've come out of medical school with. And Mark Klein, the doctor who runs it, says he has to turn away 2 doctors for everyone that's accepted into the program. Such is the enthusiasm for it in America. So I do think that this notion of an uncaring American audience because things are too foreign is exaggerated in the media. And I think we're always looking for ways to better engage the audience, but I think it's an exaggeration to say that Americans don't care about this kind of stuff. However foreign it might seem, it really isn't that foreign to them.
And just a postscript on that, certainly all the research that we have, we know that whatever the general American audience feels, that our particular audience is very, very interested in international stories generally, and I think very specifically in this kind of story. So it's part of our mission, but I think we're satisfying what our audience comes to us for.
What are the other 3 countries with polio?
In India, Afghanistan, and Pakistan.
Because in the Cairo speech, Obama promised to do away with polio.
He did.
We'll just do the questions at the end of, we have 2 more people to speak. And speaking of solutions, I think Michael's going to talk a little bit about the perspective from the Gates Foundation.
Okay, thanks a lot. Thanks very much for having me here tonight. I think there'll be some very interesting juxtaposition when Matthew has a chance to speak as well about some of the work that he's done on our behalf, but also that speaks to some of the sense of where the public is right now on these issues. I thought I would just very briefly open up by setting some context for the type of work that the group at the Gates Foundation that I work in engages in, which again is global health policy and advocacy at its highest level. And not surprisingly, given the organization, our core goal is to accelerate the achievement of health outcomes in developing countries in line with our core mission that all lives have equal value no matter where they're lived. In the context of our group, we then focus on 3 key areas within a policy and advocacy lens. The first is trying to generate more resources, money, other types of resources, better resources, as it were, and also in the current economic environment, often trying to maintain commitments that have already been made, because in so many cases there have been some significant advances and significant commitments that have been made by donor governments that we need to make sure don't get lost in the economic crisis that we're in. Second, the promotion of more effective policies and generating quality evidence of the needs and gaps that then would inform those policies in donor countries, developing countries, and within the number of multilateral organizations that can have such an influence on the reality of what it means to execute and to deliver the tools that are needed to help people. So whether it's working on taxes and tariffs in an African country to make sure that when the goods hit the dock, they can actually get off the dock, all the way through to the pricing and procurement policies of a global fund and the like. And then third and finally, and the subject of this evening, is looking at ways to increase the visibility and awareness, not only of the challenges that I think in some ways have been articulated thus far this evening, but also some of the very meaningful successes and progress that's been made in the area of global health in recent years, and that's vital to underscore that in many ways these investments are beginning to pay off, and that the public's dollar is having a range of positive impacts. From our perspective, we think it's vital to keep global health in the public dialogue for many reasons, the first of which is to reinforce the political will. That in many ways, and again, I think Matthew will speak to this in a moment, a political will that in many ways is far ahead of the public in terms of how far they've stretched themselves in order to get the resources that have been committed to date in recent years. So I think Matthew will certainly flesh that piece out a bit more in a few moments. But what I thought I might do now is just give a set of examples to contrast from the obvious support and partnership we have with the NewsHour that's been well described. There are a range of other ways that we seek to engage the public in the work of global health that can really, again, underscore this political will that we think is so vital. So I'll just give a few examples, and then I'll close with maybe a few broader elements that we think one should keep in mind. The first example I would give is a large partnership we have with the faith community. When we looked at the faith community, in many ways it was a reflection of the work that Rotary has done with polio. When you look at the power of Rotary International, it wasn't just that they committed to a single cause, it was that they were a mass member organization that had a pre-existing constituency and infrastructure that could be tapped for education, for awareness, for volunteering. So by one engagement by the World Health Assembly with Rotary, you had 1.3 million Rotarians on your side. That's a game-changing opportunity. We looked at how that could apply to other global health issues and to other organizations in the United States that could have some of those same characteristics. And we ultimately are now in partnership with both the United Methodist Church and Lutheran World Relief on behalf of both wings of the Lutheran Church, both of whom have committed to raise $100 million for the Global Fund to fight malaria. But more important, or equally important to the financial commitment they've made, is that they've agreed to activate that constituency. That's 19 million Americans. When you combine the Methodist Church and the Lutheran Church, you've all of a sudden, with one partnership, you've engaged, tens of millions of Americans around a global health issue, and you've, rather than had to reinvent a capacity to reach out and engage them, you're able to work with the existing infrastructure they've got. And then, as I mentioned earlier, prior to the session starting, for them it was not only strategic because they thought it was core to their mission and how they wanted to engage their denominations here in the United States, but they also saw it as being in alignment with their fellow congregants in developing countries, many of whom are solely relied upon for the delivery of these health interventions. And so these partnerships, with the Global Fund, isn't just because they can raise awareness and excitement and motivation here on a global health issue. It's because they can also connect that faith delivery capacity in developing countries to some of these multilateral funding instruments that might otherwise have never talked to one another. Another example is just broad mass outreach in general without a pre-existing constituency of the same clarity. And a great example of that would be the work that the American Idol TV show did over 2 years ago. Over a period of 2 years, the most popular TV show in America took a number of issues, but with a predominant focus on global health and development issues, and put in front of the American public global health in a way that was unprecedented in terms of reach. On a financial level, it raised $130 million for those issues, for those causes. But it reached an entirely other level of actor, which was terrific. Two other examples. what we were joking earlier, Ashton Kutcher a few months ago, some of you may remember, decided to challenge CNN because he became a champion of malaria no more. And within a week, no matter where you were in the world, if you were watching CNN, you were aware of malaria, because of Ashton Kutcher. And what it spoke to was a public becoming increasingly engaged. Maybe I'll just switch to some elements here, and then we can pick up some more later on because I think they'll come out. I think to me there are 4 key elements to keeping global health in the public dialogue. I think these elements may also apply to other issues, but let's work with them here. The first is create an awareness, but also an action. And in all the examples that we're talking about, while we're mindful that the broader the community and the broader the constituency, the higher the impact it can have from a political context as well as an engaging of the public. But you need to give people something to do. Whenever possible, operate within the means and channels people are already familiar with. And I think the examples, whether it be a connection to a popular TV show or whether it be your local church, you immediately leap over a trust issue if the people that are talking to you about this issue are people that you already trust. Third, continually report back progress so that people feel increasingly connected and attached to the issue. And then fourth, make overt the connection between their commitment and how it affirms elected officials' commitment to global health. Everybody loves leverage, and the more we're clear that the increasing support that the public shows and demonstrates to these issues undergirds these political commitments that will keep the resources flowing or maintain the commitments we have are vital. So it's sort of a different dimension on how to keep this debate in the public beyond the media piece, but really tapping into these existing infrastructures or engaging the public in a very direct way.
Michael just did the impossible. He made me feel positive about Ashton Kutcher, Twitter, and American Idol. So
and actually, I feel like I should at least maybe I'll say one more thing. So measles deaths have reduced 70% in the last 9 years. I feel like compelled to give one or two positive statistics from where we've come. So 1 million people died from mostly under 5s from from measles in 2000. And that's reduced by 70% through these massive immunization campaigns that are now increasingly applying different interventions. Bed net coverage has gone from 3% to 50% in a number of African countries in literally the last 2 or 3 years, thanks to a very significant and focused effort by a few key champions. So I think it's important that as tough as these issues are, we have a responsibility to also always couple the challenges with the progress that's being made.
Clearly there are good stories out there as well. And Matthew, you can tell us about what the American public thinks about this and maybe how to control them as well.
I don't think you can control the American public, though people think you can. I'll pick up where Michael left off, which is that the leaders in the United States and what they've done on international investments are really way ahead of where the public is. And they are out on a limb. And if the people that have interest in global health don't do the job that's necessary or a better job in communicating what's going on, somebody's going to saw off that limb because the situation exists now where funding is at such a place, even though many of us in this room believe it needs to be more, that's not where the American public is today in that. Interesting, when I look at public opinion, and we've done a ton of research on behalf of the Gates Foundation and analysis and coming up with messaging and what's the right way to approach this issue, it's best to find out where the public is, not to try to convince them they're wrong. And many times people go into campaigns and messaging and says, oh, the public is this way, and we're going to tell them they're wrong, and we're going to convince them what to do. And it's really the most successful messaging and ways to engage the public is to find out those rivers of public opinion and those rivers that exist in the public and try to ride those in a place and to the destination that everybody feels good about. Where the public is today on global health, first, they have no idea what the term global health means. The public either says they don't know, or most of the public says it means the health of the planet. It has to do with global warming or climate change or something else to do with the environment. So even the term global health on its own is a difficult one for the public to grasp. Secondly, where we are today, because of the situation that exists economically and what's gone on over the last few years, both nationally and internationally, is there's a tremendous problem fatigue. People are tired of hearing about the problems. And so when you approach people through a prism of problem, presenting, look at all these people dying, look at all these people sick, the first thing they do is tune you out. when they hear that, because it's just like, yeah, I know about all those problems, I hear about all those problems, I got problems, they got problems, everybody's got problems. And so one of the things in the messaging is you can't start with a problem. We have done, in the field of global health, and the advocates that have done a yeoman's job over the last 10 years in telling people about the problem in global health in the world. But now we have to start telling people actually what's been done, what are the success stories that have been accomplished. Third, we're at a time of limited resources. And it's not only limited financial resources, how do we divide a budget that's limited, but limited attention span resources. The ability of people to focus on things. There's so many avenues for people to look at information, gather information in so many different ways that people's time in order to grasp them and hold them and make them pay attention is limited in what we have today. And so how do we talk to them in a way that they will engage them on an issue like global health? One thing is, from all our research, the American public does care about this. They care. The vast majority of the country cares about it, would like to see something done, believe it's the right thing to do, believe it's the moral thing to do. But in their mind, at the time is where we exist today, the public's first approach is, yeah, I got problems, but I have not heard about anything that's been done that's positive on global health. So they've heard about all the problems but haven't heard about the successes. When you ask them about what news they've heard on the issue of health internationally as broadly, 2 to 1 say it's all been negative. So by 60 to 30, they say it's been negative news, not positive news. And when they believe that, if they believe that they heard about all the problems and they believe it's been negative news, they then begin to believe the programs that we're spending on all this money must not be working. That's sort of the, dot to dot to dot. They connect that dot and say it must not be working since they haven't heard about it. And so in successful messaging, as obviously the folks at PBS have seen and how they approach this issue, is you got to start with what's actually worked. You can get to the problem's big and we can do more, but you have to start with here's what's actually happened. And when you approach it as a success story, for the public's mind, it's not enough to approach it as we saved a person's life. They want to see some sustainability to it. And when we did a ton of focus groups around the country, the most common thing they said is, we shouldn't just give them a fish, we need to teach a man to fish. Which means they want to see that at some point there's going to be some self-sufficiency, that people then can grow their community, village, or whatever economically, and they're going to get to a point where they're self-sufficient and they can do it on their own. That is the public's view of success. It's not just somebody's life got saved, but now there is some long-term sustainability to this and that people now are self-sufficient on their own. The fourth problem is accountability in these programs that the public has seen. And so if they haven't heard any successes and they haven't heard it's worked, they automatically believe that nobody's being held accountable for this. And there's 2 places for that. It's interestingly enough 2 places for that the country believes. First is there's corrupt foreign governments that are taking all the money. Since all this money's been spent and they haven't heard any successes, therefore somebody's taking the money. So it's corruption in foreign governments, or it's inefficiency in our own U.S. government. So it's a government, in their view, if they haven't heard about success and haven't heard about positive news, it's a governmental problem, either a foreign government problem or a U.S. government problem. And finally, I know we'll have a conversation more about all of this. The thing that is, I think, necessary to be done is you have to connect to people's values, not to the program's value to the national interest. I'm going to say that again. You have to connect to people's personal values, not to the program's value to the national interest. And many people in global health like to talk about, oh, this will help national security. Oh, this will help. We'll be able to grow markets economically if we do this, and we'll be able to have markets that our products can be sold in. And we too quickly try to tie it to a national interest. National interest arguments have to be seen not as reasons, but as benefits to it. And when I talk about connecting to personal values are things that they believe in the American's own life. Accountability, I have to be accountable for what I do. Self-sufficiency, this whole idea of pick yourself up by the bootstraps. And that I have to do this on my own and I have to do this. They want to see that's actually what's being done in foreign countries. And finally, when we have this environment, it's actually, when I was going through this conference here, it's interesting, the inherent tension that exists between the debate on U.S. health care and the discussion of global health. And because what that does is when that conversation exists in the American public's mind, when you have a lot of people talking about the U.S. healthcare system, what the public's then going to think is, it's like, well, yeah, that's what we need to focus on. Why are we talking about global health when we have all this healthcare system problem, and everybody's talking about the problems in the U.S. healthcare? And so even in this conference, actually, there's a tension that exists in gaining people's attention on one of those two issues. I think fundamentally we have made the mistake many times talking about this issue. When we try to make this a conversation between, we have to pick between at home and abroad. Many times we present the argument like we're spending all this money, we should spend more of the pie, less at home and more abroad. That is never going to work in the American public's mind. What the argument has to be presented ultimately is a choice between what works and what doesn't work. So it's not a question of between should we be investing this at home versus abroad. It's a question is, are we doing programs that actually have successes, that are accomplishing things, that are getting stuff done, that are saving people's lives, that are building self-sufficiency, and are we doing things even at home that we shouldn't be doing that aren't accomplishing the goals? And so when you present the argument about global health and why people shouldn't be involved, it's really you're never going to get hurt if you do it as a home versus abroad. You can get hurt if you do it as a what works versus what doesn't work. And so ultimately, it is about telling stories like the folks at PBS are doing in both an anecdotal way, the story of a man or a woman in a village, and macro way. But you're not going to get hurt until we begin to tell the American public less about the problem and more about what's actually been accomplished internationally.
Okay. Thanks very much. I'm going to ask a few questions myself to the panel, and then we'll open it up to the audience. And I'll start with one that just occurred to me here. If global health itself is a term that doesn't work, if it's easily misunderstood, if it's not very precise, what should we be using? Because you're right, it's what does that mean, actually? Just something we sort of slapped on here, but what should we be saying?
Well, that's an interesting question because we've had this conversation internally at the Gates Foundation about this. I think that if we're going to talk to the American public, there's really no reason to use the term global health. There's no reason to use that broad term. It's fine, I think, when we have conversations internally or among the U.S. government or international government. But with the public, I don't think we need to say global health. I think we can approach it as diseases that affect poor countries or some other way that we can do it that doesn't use the term global health. If we're going to say the term, and if my view, my own personal opinion, if we're going to use it, I think we need to add the word human in between global and health. So global human health if we were going to make a change. But I don't think it's so much important to change that term, but change the way we actually describe what we're doing to the public.
Because I guess by using the term global health, we're essentially drawing that home versus abroad division that you say is problematic.
Well, it's not necessarily. It's only problematic in that we then try to force the choice. We try to convince the American public they should be spending less money at home and more money abroad. That's when we get in the problem, when we try to take limited resources and explain why they should be doing more abroad than at home, as opposed to a program-by-program discussion about what works and what doesn't work.
Thanks. Michael, you can talk about this as well. The economic crisis, how has that impacted this movement? I mean, this feeling that there's a country that's turning inward, that is very concerned about its own problems, getting through the day, quite literally. Has that impacted funding? Has that impacted attention to really, caring about problems that are happening outside their own homes?
Well, from a citizen perspective, I think while overall donations have certainly slipped this year, I think they're down 6%. There are a number of examples of where significant resources continue to be asked for and raised from the public through all the campaigns and all the activities I just described. Actually, I'll give you one example outside the U.S. because I think it actually is relevant, potentially coming back to the U.S., which is about 4 months ago, Comic Relief in the U.K. Some of you may know Comic Relief, which was started about 25 years ago, as a major education and engagement program for UK citizens, really targeting youth in particular. And every 2 years they do what they call a spectacular event. It's Red Nose Day, and it's very comedic, and the entire country gets behind it. Well, and despite the economic situation that we're all in, they raised 65 million pounds, in Red Nose Day, which was far and away their most successful year ever. What's most exciting about the Red Nose Day Comic Relief example is in many ways they have raised a generation in the last 25 years in the UK that's been educated and made committed to these issues. And so it becomes very natural as part of your development and growth because it's every other year. It's in every school in the UK and the like. And so it raises the question. So your short answer to your question is yes, there are multiple examples of where millions of dollars from the public and engagement and all sorts of ways is continuing on a number of the issues. Malaria is perhaps among the most recent that has really gathered a lot of momentum with a wide range of the U.S. public that's been engaged and targeted on that issue. But the idea that you could then take it a step further, imagine an American Idol gives back every other year, that over a 20-year period, and you might well find kind of like a Sesame Street generation, you have a generation of Americans that are born and raised with these ideas as a natural part of their mindset, which then gets right back to ensuring the level of political funding and support that we want to have.
Well, I'm going to add something to that. And it's interesting. About 6 or 8 months ago, I was involved in some research that asked Americans to describe themselves, and it was done. These folks did this research, and they used Carl Jung's way of how people look at themselves and these archetypes or whatever. And the number one dominant way the American public described themselves was orphans. That's how the American public viewed themselves, as orphans. And what the American public was saying is, it's don't talk to me so much about specific issues and specific programs, but give me a way that I can connect to a broader community and feel part of something, that I'm not just an isolated silo somewhere, which is why the American Idol thing works so well, because it gives people a sense they're a part of something. They're in a community. They can text each other. They can email each other. They can be part of something bigger and broader. And so I think part of this is how do we speak to the public as a way to bring them where they want to be, which is part of a broader, whether it's domestically or internationally, broader of a part or community that they feel connected in a real way, authentically, to somebody in Africa or somebody in India or somebody in Pakistan or whatever it happens to be. So it's not just a programmatic thing. It's a way that to make Americans feel connected, because right now, especially in this economic environment, they do feel like they're left in their own silo, and they want to be outside of that in an interest that's not just a self-interest.
My NewsHour colleagues can weigh in on this a little bit as well. This yearning for community, which I think underlies a lot of different media successes now. I mean, having one that's integrated, having one where you're not just being spoken to, but actually being part of the community. Where does that leave the more traditional media that we work for, where you are, in a sense, you're putting on a show, speaking to the audience, or you're writing a story, speaking to them? Is there a risk that doesn't have the same resonance that these more interactive media would?
I'm not following your question.
Well, I mean, simply that it's pointing out whether it's you're looking to groups the media, this feeling of needing for community, where you want to be part of the solution, you want to be part. You're voting if you're part of American Idol. Now, with traditional media, whether it's a magazine or it's a TV show, that option is not the case. You're basically putting on a show, you're going off to an audience. Is there a risk that has less resonance than media that would be one that is more interactive?
Well, you may be right that interactivity is something that we are discussing a lot, because the Internet has permitted interactivity that we haven't had that opportunity to use before. And I think, as Ray alluded to early on, our goal is informing the public, but not taking an advocacy position.
Not behavior mod.
Pardon?
We're not in the business of behavior modification.
And it's and the overlap here and the connection in the association is obviously the Gates Foundation is interested in an informed public, and we're interested in an informed public. But I had a very interesting and I think important conversation just about a week ago with someone from Gates, where we were talking about the grant and the progress we've made. And this individual said, we're really not interested in terms of the relationship and what stories you cover or how you cover them. That's your job. You go ahead and do that. We believe that an informed public will be important to the goals that Gates has in terms of whatever advocacy is involved. So there is an important firewall between the two in terms of the editorial approach that we're using. And so our guide is we're looking for stories that people will be interested in, that are potentially having important political or health impact in the countries they're in and even on our country, and we're moving ahead to report on that. And not as concerned with, we want the public to be informed, but where it's going to fall in terms of the support for financial programs, support for programs overseas. I don't know if that's responding sufficiently
Well,
to your question.
how do you, there are so many potential problems you could pick to do stories on now.
Right.
They're quite limitless. How do you pick the ones that you're going to do? I mean, how do you pick the stories that'll have the most resonance? If you're not, of course, like a Gates Foundation, you're not trying to pick based on what the most good you can do, but what the best story will be.
I think you look for where are the stories with the widest impact, where are the stories that are affecting the most people, where are there developments that are new, where there has been improvement or progress made, where is news being made. Ray, why don't you talk a little bit about what motivated us to go to the 3 places you've gone?
Well, the interesting thing about the trip to Mexico is that originally we were going down there to do another set of things altogether. There's been a big public debate in Mexico about family planning and about abortion. And we interviewed the mayor of Mexico City, who is not analogous to the mayor of London or the mayor of Washington, D.C. He is the chief executive of a city of 22 million people, and really politically one of the straws that stirs the drink in Mexican politics. And he legalized abortion inside the Federal District of Mexico, setting off an enormous public debate inside Mexico about the continuing influence of the Catholic Church, methods of population control, and it was fought all the way to the Mexican Supreme Court. So we were going to do that. We were going to do something on the very interesting experimentation on providing health care to families in rural areas in Mexico. And then H1N1 happened. And we pivoted, changed our tickets, and ran down there and tried to very quickly catch up with a story that was already starting to gain speed and also starting to become an enormous story on this side of the border. That was one of those cases where we didn't have to do a sell job to Americans on whether they should care about a disease that was affecting Mexicans. This was, once it leaped the Rio Grande, it was a very important story on the American news budgets, on all media, almost immediately. And because we were already there, because we were already doing long-form reporting, I think the Mail showed this as well, Les. We gave a very different impression of the Mexican response to the disease, which actually, once the dust settled, public health authorities around the world started to praise Mexico for its quick response. But if you remember the first days of the epidemic, it sort of reverted to type of North American reporting about Mexico, which was all about corruption and incompetence and lying and authoritarianism and all this other stuff, because that's the way the American news business talks about Mexico. So we just plugged in H1N1 into those archetypical stories, and it became that. But I think we were doing something different, and we were able to be nimble and jump on that story as it was leaving the station. I think if you're going to do a global health budget for a news program, you have to talk about HIV. So South Africa, because of its recent history, because it had a health minister for years that, along with the president, denied that HIV causes AIDS, did not begin antiretroviral treatment for its infected population. we could have done it in any number of countries, but we chose South Africa because they had had a 180-degree change in emphasis, a 180-degree change in approach to their own people, and it was actually starting to pay off. And also, South Africa is home to the world's most advanced clinical trials on a TB vaccine. So we went to the little town in the mountains north of Cape Town, where they are testing what may become a very effective answer to those places where tuberculosis is still widespread. And if you cut it off with the children, tuberculosis is very heavily spread during sleep because in a lot of places in the world, families still sleep in very close quarters in not well-ventilated places. And when you're horizontal and you've got TB, you cough deeply once you enter that deepest part of sleep in the early hours of the morning. So there's everybody sleeping in one room, breathing the way sleeping people do, nice, full, deep breaths, and somebody's in there coughing and expelling tuberculosis into the air, and everybody breathes it in. Well, you know, Americans don't even know how you get tuberculosis. So anything you tell them is something they didn't know. So we figured South Africa was a good hit for that. And after H1N1 began to pop up in dozens of countries around the world and in hundreds of cases, we went to Geneva and interviewed the Director General of the WHO about WHO's decision to raise H1N1 to the highest alert level on its table of infection and infection response, triggering all kinds of responses on the part of national departments of health throughout the world. Tanzania, well, you know, again, in some of these cases, there are a lot of different countries you can go to cover these stories, but there's a bunch of diseases that affect over 1 billion people. And oddly enough, they're called neglected diseases. They're not neglected, but the big three get so much attention, that is HIV, tuberculosis, and malaria, that diseases that cut short millions of lives, render people unable to work, reduce the quality of life for hundreds of millions of people around the world, just don't get talked about very much. So we went to Tanzania to talk about neglected diseases and some of the responses that very clever people are coming up with to, in a country where they only have a couple of bucks per person to spend on national health, to effectively and economically treat diseases that just take a little bit of attention. In the case of river blindness, if you give somebody 1 pill per year for 15 years, 1 pill a year for 15 years, you cure them of you eliminate the microscopic worms in their system, but you also break the cycle because the biting flies that spread these microscopic worms aren't picking them up from human beings anymore. It's an incredibly effective thing, but it's very difficult in these places to keep track of somebody for 15 years. But they've designed effective, smart, and economic strategies to do it. So if we were looking for good news, this was one of those good news stories as well.
Great. I'm going to ask one more, and then we'll open up to the audience. Obviously, the NewsHour, with the help of Gates Foundation, has been doing a great job in doing a really wide range of these kind of stories. But mainstream news, newspapers, magazines, network news, cable news, all cutting back on global reporting. That includes global health or whatever term we end up coming up with. What's lost there? I mean, to see that form of the media really retreating from this kind of reporting, what are we losing?
Well, I want Fred to comment it too, but just quickly, we're losing a broad understanding. We're not reaching the audience we need to, and it's a loss within our industry as we see the shrinking that we're talking about, because it always took more resources. And I think at a time when I think people have a larger worldview than they ever have, because all these technological advances have given us insights and ability to go all around the world, it will force us, I'm afraid, to be more insular in our understanding. Fred, what's your
as the guy who does downer stories, I like to look at this as the glass half full in many respects, and get us to multi-platform 101 in many respects. And one of the benefits that we have in the new world, given the extenuating circumstances and the dearth of this kind of material, is that we have a lot of it living on our website and others, no doubt. The story of what's happening in Tanzania. I did a piece out of Bangladesh a year ago. The most crowded country on earth, Bangladesh, has 144 million people, 148 million people in a country the size of Wisconsin, which has 5 million people. That country is on the verge of eradicating tuberculosis with a DOT program. It is a truly spectacular and very cheap program. There's a wealth of that kind of material that isn't necessarily boosterish, but it is bringing out there and making accessible at a viewer's convenience, or at anyone's convenience, these stories of success, of what is working, and, of course, the underlying program. I think that has become now our modus operandi, is to find the right story, the story that illustrates the problem without sinking us into the misery, that underlies so much of the disease. And the one other example that I want to throw out that is illustrative in a much broader sense, that gets us beyond epidemiology, is to get into systems. We did a piece 20 years ago about a little eye hospital in India called the Aravind Eye Hospital, which was a promising facility. It had a nice, it married compassion with efficiency and in the real embrace of technology. It's now, we have a piece on the shelf. It's going to go on the air one of these days. It's now the largest eye care facility in the world, and in their 30 years they have done 3.5 million cataract surgeries, restoring people who would otherwise go blind across the developing world. It's become a model for any number of, I think they have exported the methodology to 120 countries. The point being that this began with an idea hatched by a fellow named Larry Brilliant, who's now at the Skoll Urgent Threats Fund, but was at Google, the man responsible for eradicating smallpox in India in the 70s. And he is talking to us in a web-only piece that complements the story of Aravind, that says, in the foundation world, this is the jackpot. We seeded this thing. It has grown to many times the size of the foundation that seeded it. And it is teaching the rest of the world a number of things, including ourselves. The guy who runs it told me there is no reason why we can do a cataract procedure for $100 with a foldable intraocular lens implant that costs $8,000 in America. There's no reason, or the reason cannot be a labor cost differential when it's that large. There is a lot going on here systems-wide that can really teach. All of that is living on our website and is living there forever, and we swell the audience one at a time, in front of their computers now, and it's different.
Any questions from the audience? Right down.
I'd like you to comment on a linkage problem that I perceive, or maybe I don't understand. Your ability to motivate the audience. Your ability to inform and get the sympathy of and get the attention of the audience for this compelling disease-ridden area that can't extricate itself from it is one thing. But for the 300 million Americans that aren't in the professional field that you all are in, what is the urge to action that you want them to do? Do you want them to send money in? Do you want them to write their congressman? Do you want them to get a different division of the 20% from the 80% that you spoke about? What is it exactly that you want them to do when they leave as effective a program as Gates or the NewsHour does, or in our scene, the films tonight, which is everybody in the room would agree is very stirring. But what is the urge to action that you specifically want? I'm reminded of a simple program in the March of Dimes that many of us remember, where you learned about polio and you gave them a dime or whatever the currency was. But there was a specific linkage that didn't just leave you with, this is devastating and humiliating that I'm part of a race that allows this, but it doesn't leave me with an urge to action that's clear for what it is I should do. Could you comment on that linkage? And am I missing it? Or is it something that in your ground neutral position of being informers and educators, you stop short in?
Well,
thank you.
Michael and I could probably answer for, and Michael can. There's going to be a difference between what Michael and my answer to that would be, the Gates goal of that answer, and obviously PBS folks' answer to that. And Michael probably can speak to why the Gates Foundation has an interest in this in public investments. So, I mean, ultimately, it's to sustain or increase the investment in public dollars on international health. That's the goal, ultimately. That one step removed from that goal is to begin to build a political environment that you can motivate an informed part of the public to encourage decision makers in the U.S. government, the administration, or Congress to sustain or increase public investments in international health. And there's many steps before that, write letters, phone calls, all of that, but it's a stepped process that the ultimate goal is to sustain or increase public investments in international health dollars. And
you nailed it. I'll just add one or two. I'll just use an example from my former job at the UN Foundation when I was a grantee of the Gates Foundation. You know, and one of the projects that they funded us to do was to help launch what is now known as the Nothing But Nets campaign. You know, which was a very specific campaign that had a very clear message, which was, you know, $10, you know, send a net, save a life. And so this kind of goes to, now everyone understands that you're not going to eliminate or eradicate malaria merely by engaging in, you know, by delivery of bed nets, but as an entry point for a public to understand that ranged from the bishops of the Methodist Church to a 5-year-old girl in Philadelphia who, you know, set off a firestorm in then her part of the Methodist Church, you know, and sort of engaged sort of like a children's crusade on that issue. You know, what the core point I want to make is even when we did that, it was partially constituency mobilization, but what it was really for that issue of malaria, but it was really about all of these campaigns were about building an architecture of constituencies to care about this issue, to underpin political support. Now, I want to be very clear that, you know, in the range of investments that we're making as a policy and advocacy group, I think you made a very important point that there's a diversity of those types of investments. And while we have very specific objectives in certain investments with civil society partners like a UN Foundation or like a One campaign, which gets much more into the direct political side of writing letters, engaging at a district level with your elected officials, and like that's a wholly other type of relationship than I think, as you exactly right describe, we have with the NewsHour. So I think that was an important point that you made, and we 100% support that. But the answer to the question is my first element, which was create an awareness, but also an action. And you have to connect at any level, you know, this information that you're providing with an action, or you give people from the not the NewsHour perspective, but from everything else we're doing. And then what you need to do is step back and look at how you can tie all of those to the larger objective that Matthew described of undergirding or pushing for a level of government support.
I'm going to be very simplistic. Our objective is for you to have a better and clearer understanding of the world that you live in, and to understand those phenomenon that may affect your life directly, may affect your pocketbook through what your government is doing, may affect your worldview. And we're not looking for any more linkage than to provide you the understanding of issues which we think may impact your life directly or may impact the country or community you live in. Ray, what would you add to that?
When I was a producer at ABC, I used to fight with the people who put on hourly newscasts about whether we should be covering the Central American civil wars. And they would make fun of me and say, nobody cares about this. And I would say, well, look, it's close and we're involved. So that passes my sniff test for whether or not it belongs in the newscast. About 3 years in, out comes a huge poll that says most Americans have no idea which side we're on in any of these countries. The newscasters that I was fighting with said that this proved their point. I told them that it proved my point, that we hadn't been telling the story all along, so that our government was very heavily involved, and we, the governed, had no idea how to give any consent or lack of consent to what was going on, because we didn't even know what was going on. That example just replicates over and over again. When students came over the walls of the American embassy in Tehran, everybody started scrambling to try to explain to people what the nature of American involvement in Iran had been for the past 50 years. We were flummoxed that any Iranian would be mad at us. Like, how could they be mad at us about anything? And this is not an Americans are stupid story. It's a story about how if the national storytellers don't give you a full and balanced view of the world, everything that happens is a surprise. Whether it's a civil war in Nicaragua or students or activists or whatever they were, shock troops taking over an American embassy in Tehran, or people flying airplanes into buildings in Lower Manhattan. It's all a surprise because the world makes no sense to you. Well, I don't want to be in the enabling profession of having the world be a mystery to Americans. So what they do with that information is up to them. That's what consent of the governed is all about. But I don't want them to say, I have no idea where this is or what this means. So I'm doing my little bit.
Sure, go ahead. Just from my small world of undergraduate education as well, I would not discount the power of this kind of material to move young people to do things, to action. A story about Paul Farmer in Haiti might get 3 students from my course to look for a service learning experience, which is one of the hottest things in undergraduate television, undergraduate education. And I think the slow, tedious, incremental process of bringing this material to young minds, is something that we also need to be doing.
There does seem to be a difference, though, between the kind of foreign reporting you have described, and whether it's what's going on in Iran for civil wars in Central America, and these kind of public health problems that, especially if these stories are being done with some work with a group like the Gates Foundation. I mean, wouldn't you think that someone would watch these and be moved to do something about it, whether that be to be part of that architecture of the constituency that you described earlier? And how do you keep that firewall that you mentioned before, keep that alive and make sure that there isn't a co-opting going on here?
Well, I think it's the motivation. The motivation is to explain. The motivation is to provide understanding so that the viewer and the user of the information can then use it in terms of how it affects his or her life or his or her country. But it's aligned. We may all personally agree with the advocacy of the Gates Foundation in terms of is it hard to be against eradicating illness or in favor of ending the kind of misery that we see out of the world. So personally and emotionally, it's something we all feel for. But we can't let that be the decider, and we have to separate ourselves But we have to say, is this information both of interest and of importance, not only to the general viewer, but we know in terms of our audience that we have a lot of opinion leaders who watch our program. And helping them understand, especially if they're not in the field we're talking about, is also an important goal to achieve understanding. And it may seem odd that we would draw that line, but I think most of us do.
One thing I would add to that is, because we also would see an ecosystem of the different approaches that you take to inform,
right.
You know, what I would hope would happen is that some of our advocacy grantees would be seeing the work that you're doing, and they would be operating off of that in their own way, appropriate to their mission and their mandates, you know, and making use of the material on the website, making use of the story, making use of the information. You know, that's the benefit of the interactive environment that you operate in. So in many ways, you're able to do exactly what it is that's right for you to do, and it's entirely appropriate for some of these other organizations to work off of that to advance and to motivate their respective constituencies that they want to then draw or call to act in a way that doesn't necessarily affect how you do your work.
There's also, I'm going to add one other thing. There's also a difference between today and what it was 10 years ago. That people no longer believe that geographic boundaries can stop the spread of disease, which is what the American public had believed for a long period of time, that we were over here surrounded by two oceans, that we have this. And now when they see stories, not only is it swine flu, if a disease is somewhere, and because of air travel and because of all of the smallness of the globe now, you know, whatever it happens to be, some disease in one place, the American public, or they hear a story about somebody on an
West
airplane.
Nile virus,
yeah.
which didn't exist in the United States just a couple of years ago, is now fully established in all 50 states.
So there is a sense now that the stories of a disease in a foreign country could have a direct effect on somebody in the American public, more so than they believed 10 years ago.
Right. Sorry, just two last questions first there and then here.
Yeah, could I just continue this a little bit? I was going to ask this earlier on, and the way you've touched on it. And I'm going to turn it into a nasty question, but you have to realize I'm a big supporter of the NewsHour and really believe in it. You're the best news broadcast on the air. But the nasty question is this. Basically, the Gates Foundation has bought, 20 hours or whatever you said, or a certain number of stories on a given theme. Now, you have, as you said in your opening remarks, there's a limited number of time which you can spend a year. Now, Les, you've been very careful in how you've explained your motivation, and you've stressed the firewalls. But it would be so easy, particularly as you're pressed for money and budgets and you want to keep up your activity and your global coverage. Say I'm interested in science diplomacy, for instance. Maybe we could arrange, $1 million for you. I can't, but anyways, as an example. $1 million for you if you would give me 10 good hours over the period of a year on science diplomacy. And that might motivate some people in other foundations and other institutions or even companies to support the kind of thing that I'm trying to do, which is also wonderful for humanity and building relations and all those other things. But you can pick a dozen subjects like that. So didn't you have a little bit of anguish inside the institution as to whether you'd take that grant, and a lot of attention on building those firewalls so you'd be as neutral as possible in doing so?
I don't think that's nasty at all. And I think the answer is we do have a lot of concern about that. And if we had our preference, we would prefer that foundations give us money and we spend it in any way we want to spend it. We have not been able to raise those kinds of resources. So the line that we've drawn two lines. One is the one I've talked about, that all the editorial decision-making, the selection of the story, the editing of the story, the production of the story is solely within our control. But we've drawn another line, and you picked a point which I think is sensitive, where we have to be careful. We have accepted funds mostly for general areas, and we've kept the specifics out of the requirements. So we've accepted funds for international coverage without any specificity of where we cover. We've accepted funds for covering health, for covering science, etc. So we've tried to keep it very broad and to make sure that those broad topic areas are topic areas that we feel universally and especially with our program is within our mission of the top stories, the top areas of public life that we think it's important to cover. Economics is another one, but then it's economics without any specifics within that. And that's how we've drawn that line. And as I said, I think you brought up something that's very important and significant and that we've been very sensitive about.
Okay. One last question right here.
Yeah, I just wanted to get a clarification about the earlier stuff that you were talking about in terms of the character of the American public. Because there's some things there that really struck me as being very interesting and contrary to what I had thought. And this also goes back to the whole issue of how do you talk about health care? Do you talk about it in terms of global health, or do you talk about it as being a continuum of human health? You said that people, and perhaps I'm incorrect in this, but you said that there was a sense of people feeling as if they were orphans. Mm-hmm. And did that mean that those people were yearning for a sense of community and belonging? Did they feel socially isolated and helpless in some fashion? And then the thing that really struck me, which was completely contrary to my thinking, is that what you said, I think, was that the most important thing, irrespective of where the story was that the Americans wanted to feel that they were making a meaningful and sustainable contribution. Is that a fair statement?
You sum up that perfectly.
So in terms of a story, it really becomes one program that I can't even think of the word at this moment, but you have U.S. stories, you have something from Britain, you have something from Africa, and it's all a continuum. But what you're saying is, and particularly if there are U.S. tax dollars involved, those are seen positively by the American public, as opposed to why are we wasting our dollars over there when we should be putting them here? Is that a fair statement?
Yeah, because that's exactly right. I mean, the first thing that the public is and where they are today, just not even talking about health care, is they feel isolated.
Right.
They feel like most of their social institutions that they have counted on have crumbled, that they have counted on, whether it's churches, the media, corporations, all of the sort of institutions that they felt gave them a sense of belonging have now been shattered in their mind with a total lack of faith and trust in them. Because of their ability to get on the internet and do that, they feel isolated from any sense of town hall sort of discussion. So all of that has created a sense of aloneness, of like I'm in my own thing and I want to feel connected. Combine that with so many messages over the last 15 to 20 years that have been all delivered and from a self-interest prism. Do this because, buy this product because it'll save you money or it'll do X for you, or vote for this person because it'll save you $1,200 on your taxes or whatever happens to be. So many of those messages have been self-interest. The public is now at a place, which I could go on a long historical argument, which is there is a cyclical thing to history when every 70 or 80 years the public comes to a place in a moment of crisis where they want to give a sense of belonging, which happened back in the 30s and 40s before. Which is actually I'm giving you a total rationale of why Barack Obama getting elected with what he had to say was not a surprise in the manner with which he talked to the American public and what he had to say. All of that's true, and so anybody that's communicating with the American public, giving themselves, whether it's talking about global health or U.S. health or whatever the issue happens to be, giving themselves that draws them out of their self-interest to a big common interest, and that they're part of something else, that they're connected in some way, whether it's somebody from Akron's connected to somebody in Des Moines or somebody from Akron's connected to somebody in Afghanistan or whatever that happens to be. All of that is crucial in getting the American public involved in any given issue.
But this is, I mean, to me, for somebody, I've spent much of my life abroad in Africa and Europe and various places. This is a huge opportunity. It seems to me. I mean, the notion that we can get the American people to think about issues as if they're, effectively global issues, but to personalize them in this way, to me is quite remarkable, in fact. And I think there really is a huge opportunity here.
Oh, I totally agree. I think there's a huge opportunity.
Yeah.
I think that's a great place to end. And I know that anyone who works in this area of global health, and we will come up with a better term at some point, is convinced that this is incredibly important. And what's really most key, however we choose to go forward from here, is to keep talking about it and keep this in the dialogue. And thank you all for helping us continue doing that tonight.